Hello, everyone, and a warm welcome to today's edition of Patcast. Today is Tuesday, August 9th, 2022. I am Rifat Mannan in California, and I am remotely joined by my good friend Emilio Madrigal, who is in Boston right now. Today, we are very delighted to welcome back Mr. Dennis Strenk, who is a pathologist assistant at Wisconsin Diagnostic Laboratories. And today, he's going to give a very important talk on specimen grossing, which we keep doing every day. But and this talk should be very useful, especially for pathology residents as well as pathology assistant students who might have joined recently. And the title of today's talk is going to be Key Concepts in Specimen Grossing. And as always, please feel free to post your questions and comments on YouTube and Facebook chat windows, and we will pass them on to Dr. Strenk at the end of the session. So thank you for joining us today. Over to you, Mr. Strenk.
All right, thank you. I appreciate that introduction, and it's great to be back here on Pathcast. So as mentioned, my talk today is called Key Concepts in Specimen Grossing. Now, if you're a pathology resident, you've probably been through kind of your intro to grossing, or I think a lot of places call it boot camp these days. So you've been through that, so you understand the basics. So the purpose of this talk today is to kind of take it a step further and expand on some of the knowledge that you already have and give you some additional tips and maybe some additional explanations about some of the concepts in grossing. So first, I want to talk about why grossing is important, and this is something that I think is not stressed enough these days. People don't understand why they need to learn how to gross and what the importance of it is. So the gross description and the Semitic sections, they affect tumor staging, and I'll give a few examples of this as we go along. But the idea is that grossing is important. It affects the microscopic diagnosis. A lot of the information in the gross description and in the sections that we submit is what determines the stage, and I'll show some examples of that as well. So it's important that you take grossing seriously, that you do it properly. So, all right, so grossing affects the staging, and the staging affects the treatment. So that means that grossing affects the treatment. Now, I went to a conference a couple of weeks ago, and there was a pathologist there who was talking about, I think the title of his talk was something like how pathologist assistants save lives or change lives or something like that. But the idea was that the grossing that we do as pathologist assistants and as pathologists, it saves lives. And he gave some examples of things that maybe you can relate to. There was, finding the one lymph node that was positive out of the many, because of course you didn't stop at 12, you kept looking until you found all of them. So you found the one lymph node that was positive, that changed the stage, changed the treatment for the patient, and might have saved their life. One of his most interesting examples was, he was talking about a patient that had breast cancer, and they had multiple tumors in one breast, and there was, when the PA was grossing the specimen, they found an additional tumor that didn't show up on radiology, and it happened to be larger than any of the other tumors, which means it upped the stage a little bit, which changed the treatment for the patient and probably saved her life. So the lesson there is, of course, make sure you're looking for any additional lesions, but also, radiology and radiology imaging is not a substitute for your own eyes. And I've had examples of this at my job as well. So that's something to keep in mind. All right, so the first concept we're going to talk about is margins. And I think this is one of the most important. So the question is then, what is a surgical margin? And I think kind of the simplest definition is, this is where the tissue is cut away during surgery from the normal tissue that's left behind, and that's the surgical margin. And I'm going to show a lot of examples of what that means. So that's kind of the basic idea of what a surgical margin is. And these are important because, of course, we know that a positive margin is not good for the patient. And, these things affect the staging, these things affect the treatment. And if you've got a positive margin, you often need to go back for additional surgeries. All right, so margins. So there's two types of margins that we're going to talk about today. The first is the shave or en face margin. And then the second type is the perpendicular margin. And these both have, these are used to show different things, which I'll go through in a few minutes. All right, so the first one, the shave or en face margin. All right, so this is generally used to demonstrate the entire margin. And some examples there, tubular structures like the bronchus in a lung, vessels in a lung or in a kidney, some other organs, of course, the ureter margin as well. These are things you can shave off the end of the margin. You can usually fit that in one cassette and you can demonstrate the entire margin. The shave or en face margin, it demonstrates if the margin is positive or negative, right? Another example is the margins in a colon specimen or any kind of bowel specimen, really. You can shave off the end of the margin, usually fit it in one cassette or sometimes two, maybe three, but you can show the entire margin and show if it's positive or negative. Now, the shave or en face margin does not show how close the tumor is to the margin. It just shows if the margin is positive or negative. So you're often going to use this if your tumor is far from the margin. All right, I'm going to show you a video right now. This is a lung lobectomy specimen, and we're going to look at how we take shave or en face margins on a lobectomy. All right, so first I'm going to measure the specimen, of course. And you'll see kind of on the left and towards the top, there's a staple line margin there too. There's actually two staple line margins on this specimen. So I'm going to deal with those first. There's the bronchus there. There's the vessel margins there. And we'll go through all of those throughout this video. And what I'm going to do, I'll use my scissors to remove the staple line. And then because that's a true surgical margin, I'll ink that afterwards. And you have to be careful when you're doing these because you want to get as close as you can to the staple line. But of course, you don't want to leave any staples left in the tissue because obviously that can't be cut. So this is something that needs, it'll require a little bit of practice to do it correctly. And it's okay when you're starting, and even now with the experience that I've had, to do this slowly, do it correctly, because like I said, that the margin is right at the staple line, so you want to get as close as you can to that staple line. So I've got that one off. I'm going to clean up the blood a little bit there so that the ink can stick. Now the exposed tissue there, that's the surgical margin. So I'm going to ink that. And where I work, we ink those orange. Okay, so I've got the margin inked. That's mordant right there. It helps the ink adhere to the tissue. Make sure I dry that off so the ink doesn't get carried over into the other tissue. Now there's one more staple line, the shorter one right there. So I'll do the same thing, trim off the staples, and then I'll ink the exposed tissue underneath. Again, cover it with mordant and dry it off. Okay, now we're going to look at the bronchus and then at the vessel margin. So this is the bronchus first, and this also has a staple line on it. You might see staple lines on this. Sometimes it'll be sutures, but you handle it the same way. Shave off the staple line or the sutures. And you can see I've got a couple left there. I'm trying to kind of pull those out a little bit. And then I'll shave off the actual bronchial margin. And you can actually do this with the scalpel as well. I like to do it with scissors because I feel like I have more control that way. There you go. And I shave off the whole margin. And then where I work, and I think this is true at most places, you put the true margin down in the cassette. That's why I flipped it over like that. And then my cassettes, of course, are off screen because they have patient information on them. So of course, I can't show those. But I put the true margin down in the cassette. All right, now we're going to look at the vessel margins. There's one. I trim that close to the staple line, and then I can cut it again right at the staple line with my scalpel. That, and then the same way, the true margin goes down in the cassette. And you'll notice the first vessel that I did, I pulled off, I pulled it out with the forceps and then cut off kind of the end of it and then trimmed it. This one, because it was a little bit larger, I could just cut off the staple line and then cut off the true margin right away. And there's one more here that'll do the same thing. Or actually two more. Okay, so those are examples of shave or en face margins. Next type of margin is the perpendicular margin. So this, like the name would suggest, this is a section taken perpendicular to the surgical margin. And this demonstrates the distance of the tumor to the margin. So it doesn't show the whole margin, but it's useful because it shows how close the tumor gets to the margin. And here's some examples of that. So your mesorectal margin, that's going to be a perpendicular margin. Breast lumpectomy is pretty much the whole surface of breast lumpectomy it's a surgical margin, and you often take those as perpendicular margins. And then a partial nephrectomy margin, which I'll show you a video of that later, those are going to be perpendicular margins as well. So here we have another video. This is a lung wedge resection. And the first thing you're going to notice about that, there's a piece missing from the middle. So we have a tissue bank where I work, and they took a piece of this for research. I think this was for interstitial lung disease. So that's why there's a piece missing. So now you'll see the staple line kind of along the bottom, going to the left. So I'm measuring the specimen, of course. And then just like with the previous specimen, I'll trim off the staple line with my scissors. Again, getting as close as you possibly can to the staples. And then that exposed tissue, that's the true surgical margin, and I'll ink that orange. All right, looks like I found another staple there. Trim that off real quick. Okay. Then the mordant, of course. And dry that off. Now I'm going to pause it here. Note the position of my scalpel blade to the surgical margin. It's a perpendicular section. My blade is perpendicular to the margin. And so therefore the section is perpendicular to the margin. And then I section that way all the way through and lay out my sections in order. Okay, so that was perpendicular margin. Now I want to make the distinction between a margin and a surface. Okay, so things like the serosal surface on a uterus, say the uterine serosa, or serosa on a colon specimen, or the pleural surface on a lung, like we just saw. Those are not margins, but they're important surfaces. So it's not a margin, so you shouldn't call it a margin, but these are important for staging. And you can often ink these margins as well. I mean, we'll ink if you've got a lung specimen that has a tumor in it, you'll often ink the overlying pleura because it's important to know if that's involved or not. And then you want to use a different color ink than you would for the surgical margins. So for example, in those previous specimens, I inked the resection margin orange. I would ink the pleural surface usually blue or black. All right, so here's a couple examples of how these surfaces can be important. So if you note where I have the blue arrow there, so this is for endometrial cancer. And you see that if the tumor involves the serosal surface, that can up the stage to the T3A. This is another example. This is for lung. And you'll see where, again, the blue arrow, if it invades the visceral pleura, that ups it to a T2. So these surfaces are important and you should not ignore them, but don't call them margins. This is the same. We had a discussion at work recently, actually, about on Whipple specimens, the anterior and posterior surfaces of the pancreas. They're not margins, but they're important surfaces. All right, so the next concept we're going to talk about is sectioning. And you want to section in a way that will demonstrate the relationship of the tumor to the margins, and also demonstrate the relationship of the tumor to any other structures that are either part of that organ or that are attached. All right, here's another video. So this is a partial nephrectomy specimen, and we're going to go through how I ink it and then how I section it. All right, so again, start off with measuring this. I'd already previously weighed it. So I've got my 3 dimensions, and you can see it. So this is the capsular surface that we're looking at right now. And you can see the area that looks kind of to the left, that looks more yellow. That's the tumor kind of bulging up into the capsule, but you'll note that the capsule is still intact overlying it. So we would expect, because the color is different, that the capsule is going to be abutting, or the tumor is going to be abutting that capsule. And I measure that area and include that in the gross description. All right, this is the resection margin then. And we'll ink the capsule blue. And then the resection margin, we're going to ink that black. Okay, so that was the mordant. Dry out the specimen. Now, I want to section this in such a way that I can demonstrate the relationship of the tumor to both the capsule and the resection margin. So I'll do a section like that, perpendicular to both the capsule and the resection margin. It wouldn't make sense in this situation to do an en face margin. And you can see this tumor takes up most of the specimen, and it does get very close to both the capsule and the resection margin. All right, and then there's a little bit of normal parenchyma there at the end. Now what I'm doing here is I'll put all these slices back together because I want to get that dimension of the tumor. Okay. Then I'll lay them back out and get the other 2 dimensions. Okay. All right, moving on to the next concept. This is description or gross description. And what you're doing in the gross description is you're documenting the specimen that is received, including all additional structures. You'll measure each structure, each organ separately in 3 dimensions and include all of those. You're documenting the tumor size and the location, and then you're documenting relationship of the tumor to any margins, to any other structures. So there's a lot of information that gets put in the gross description, and much of it is important for staging. So when you're describing, you have to remember the 2 S's and the 2 C's. So the 2 S's are size and shape. The 2 C's are color and consistency. Now, I'm not really going to go through size, so that just means measurements. So you're talking about measurements in 3 dimensions, but we'll talk about the other 3. All right, so shape. Here's some examples of shapes. Now, this is not an exhaustive list of descriptive words that you could use, but I wanted to give some examples of words that are used quite commonly, so that when you're starting out, you've got a bit of vocabulary that you can lean on that you can use in your gross descriptions. So these are some of them. Ovoid, obviously means oval shaped, round, rectangular, triangular, or wedge shaped. I use that a lot for placentas. Infarcts are often wedge shaped. Linear, of course, straight line. Curvilinear, I like that word a lot just because it's fun to say, but you can use that for skin scars, or it's a line but it's curved, so that's curvilinear. Elongated is another good word. Cylindrical or tubular, things like that. All right, I'm going to show a couple of shapes that are important, especially when describing tumors. So the first one, this is well circumscribed. And a real good example of that is, like shown in this picture, that's a uterine fibroid. So you can see the edge of the fibroid has a really sharp demarcation from the surrounding myometrium. So that's what well circumscribed means. It's a very defined edge. Another example of that would be fibroadenoma in a breast. Now, kind of the opposite of that is ill-defined or poorly defined. So this is a slice from a Whipple specimen, and you can see kind of the white area that's kind of on the bottom and towards the right. So that's the tumor. And you can see kind of the edge of that is very poorly defined. It doesn't have a sharp edge like the fibroid does. So that's ill-defined. It kind of infiltrates into the surrounding tissue. Here's another example of a shape word. So that's stellate, which is similar to ill-defined. So that kind of means star-shaped. And this picture is from a breast tumor. And you can see how the tumor has kind of a star shape, these little finger-like tendrils that are extending into the surrounding tissue. Again, that's poorly defined. And you can see quite the difference between that and something that's well circumscribed. And the reason that's important is usually, although not all the time, well circumscribed tumors are benign. Again, not all the time. There are exceptions to that. Whereas if you've got something that's ill-defined, poorly defined, or stellate, that generally means invasive tumor, which generally means malignant. Okay, so we did size, shape. Now we're into the 2 C's. So the first one of those is color. Now, not everything is pink tan, even though that's a word I probably use more than any other words I say during my day. So it's important to differentiate different colors when they're there. And then we're going to go through what is homogeneous and what is heterogeneous, because those are 2 different kind of descriptive words that are very useful. So here's an example of homogeneous. This is a sarcoma. I believe it was a liposarcoma, and you can see it's lobulated. That's another good word, lobulated, but it's homogeneous yellow tan. So it basically means it's all the same color. All right, now this is an example of heterogeneous. So this is a kidney tumor, and you can see it's that yellow tan appearance that's kind of characteristic of renal cell carcinoma. But at the bottom there, you'll see some areas of hemorrhage. And then kind of towards the top and the left, there's some cystic areas. So this is a heterogeneous cut surface. So that means that it doesn't look the same as like the previous example. There are different looking areas. All right, now a couple other good words to use when you're describing focal and diffuse, and I'll give you two examples of those. So this is an example of focal. This is a gastrointestinal stromal tumor, one slice from that. And you can see, for the most part, it's kind of pink tan to red, right? But it has those little dots of hemorrhage. So those are focal hemorrhagic areas, or you can say foci of hemorrhage if you want to be really fancy. And those are important to note. Okay, here's an example of diffuse. So these are two slices from a mastectomy specimen with diffuse fibrous tissue throughout. So you can see in the previous example, focal means just tiny little areas, whereas diffuse means it's spread all throughout. And this is fibrous tissue, this is not tumor. Another time I would use diffuse is often in placentas again, if you've got diffuse areas that are maybe more pale, or in a specimen, actually more recently from like a COVID patient, you'll see diffuse cystic areas throughout the placenta. Okay, so the second C is consistency. So for this, you're talking about what does the tumor feel like? All right, is it soft? Is it firm? Is it hard, calcified, rubbery? That's another good one. Okay, friable is a good one, and I probably should have included a picture for this one. So friable is the example I always think of for this is an endometrial cancer, because they break apart real easy. They're soft and they break apart. So something that breaks apart easily is friable. Mucinous, so it's full of mucin. Think of an ovarian tumor, your mucinous cystadenoma. That's mucinous. Gelatinous, again, it looks like gelatin, like jello. So these are all good words that you can use in your gross description to describe tumors or other structures as well. Okay, now we're going to talk about sampling. So when you're sampling your specimens, you want to look at, or you want to take samples of all the margins. So this is where I like to talk about you having a system for how you're going to gross in a specimen. And when you do that, so you look, before you start it, you look at the clinical history and you decide, okay, what sections do I need to have? And that includes all the margins. So determine which margins you need and how you're going to sample them, whether en face or perpendicular. Okay, and then the next thing you want to look at is sections of the tumor, and of course the tumor's relationship to not only the margins but to other structures, because of course invasion into other structures, depending on what they are, can affect staging as well. And then you always want to take representative uninvolved structures. So for example, if you're doing an endometrial cancer case, and you'll take sections of the tumor itself, and then you want to also take uninvolved cervix, uninvolved endometrium, and myometrium. If the ovaries are uninvolved, you take uninvolved sections of those. Same thing with like a colon cancer case. After you take your margins, you take your sections of your tumor, you're going to take sections of uninvolved colon as well, the colon wall. If it's a ascending colon, you'll take sections of the appendix ileocecal valve, things like that. So you always want to also sample your uninvolved tissue as well. All right, now sampling the tumor, kind of the rule of thumb is the minimum is 1 section per centimeter of the greatest dimension. So if your tumor is 4.5 by 3.0 by 1.5, the greatest dimension is 4.5. And I generally like to round up, so I would take 5 sections of that tumor. Now, this is the minimum. There are some times that you would need to take more than that amount. For example, I mentioned the mucinous cystadenoma in an ovary a little bit ago. For those types of things, you're going to want to take more sections, often double the amount of sections. Some other things, if you've got, an appendix that's the lumen is completely full of mucin, that could be a mucocele, or that could be a mucinous tumor. So you're going to take more sections than usual, and often with those you submit the whole specimen anyway. So just remember, this is a minimum. Also, we mentioned the heterogeneous cut surfaces of tumors earlier. So if you've got a heterogeneous cut surface, you need to take at least 1 section of each of those different looking areas. So I showed the kidney tumor earlier. You want to take several sections of the yellow tan areas, several sections that show the hemorrhage, several sections that show the cystic areas. If you're working on a sarcoma case, for example, that's been treated, there's often areas of hemorrhage necrosis. So you want to take at least a couple sections that show those areas as well. So there's a lot of times you're going to go over this 1 section per centimeter of greatest dimension rule. Also, when you're taking sections of tumor, it's usually a good idea to take sections from the periphery of the tumor with a little bit of the adjacent tissue also in the section. It doesn't really make a lot of sense to take sections from the center of the tumor, because that's usually necrotic, for one thing. And also you want to show the tumor's relationship to the surrounding tissue, because that's how you determine invasion. So generally you're going to take sections from the periphery, and sometimes that'll be a periphery with a margin on it, and sometimes the margin is not included in those sections. But generally the periphery is the best area to take sections from a tumor. And then, like I just mentioned, sections from all heterogeneous areas. These are often true, kidney tumors especially, sarcomas even more so, certain other types of tumors. Ovarian tumors are often like this. They have several areas that look different from each other. So you want to make sure that you're adequately sampling all the different areas of a tumor. All right, now we're going to go back to our partial nephrectomy specimen from earlier, and we're going to look at sampling of this specimen. So what I need to do is show the relationship of the tumor to the capsule, the relationship of the tumor to the resection margin, and then also tumor with adjacent normal tissue. So here I'm taking tumor with resection margin. So the resection margin, the black ink, is going to be along the right side of each of these sections. And you'll note that the tumor is very close to the resection margin. So these sections are important. So I'm taking all the areas where it's the closest. And again, I'm taking these and I'm putting these into cassettes, which are off screen. Okay, now I'm looking at tumor to the capsule, and I'm going to concentrate on that area. Remember, at the beginning, there was an area that was yellow where the tumor was kind of bulging up into the capsule. So I'm going to concentrate on that area. Okay, now I've got my sections of the capsule. Now I'm going to take a representative section of normal appearing tissue. Okay, I've got all my sections. All right, now I want to look at sample gross descriptions for actually this particular case. So this is the template that we use for partial nephrectomy specimens. And all the areas that have the 3 asterisks, those are wildcard, they're called in our system. So you can, it's kind of a fill in the blank. You can use your pedal to, or the F2 key to advance to the next wildcard, and then you just dictate what should be in there. And then the areas where there's brackets, those, it doesn't show up on this, but those are like drop down menus that have different choices you can use, or you can add in anything you want to fill in those areas. And then this is the actual gross description from this particular case. And you can see how I filled that in. Now, the thing with grossing templates, they're a good guideline to use, but you can always adjust them, and you should for most things, because it's not a one size fits all kind of thing. So if you've got a specimen that doesn't exactly fit your template, you can adjust your template to fit what you have. The thing I wanted to highlight on this is the area where it's bold. So this shows the size, shape, color, consistency, right? So again, the measurements, that's the size, well circumscribed, it's soft, and it's yellow tan. And then the foci of hemorrhage. I also have right after that, so it shows the distance of the mass from the resection margin, and then the mass abuts but does not grossly extend through the capsule. Again, important measurements to have. And then at the bottom, the cassette designation, that should always be at the end of your gross description and kind of separate. We do it with a separate paragraph like this. So you can see I've got the first 3 sections, mass with the closest resection margin, the next 3 are the mass with the closest capsule, and then the last one is uninvolved parenchyma. And where I work, we order a PAS stain. On any kidney specimen, we order it on the uninvolved parenchyma. So that's what the last sentence at the end is about. So this kind of gives you an example. This is a simpler type of specimen, but it gives you an example of the kind of things you need to include in a gross description. Okay, and so this is all I've got for you. These are if you want to connect with me online, these are the ways that you can do that. My email is there at the bottom. And if you enjoy listening to me talk for some reason, you can check out the People of Pathology podcast. Those 2 QR codes on the right-hand side there, those are links to, one of them is for Apple Podcasts, one of them is for Spotify, so you can scan those if you want to check out the podcast. So thank you very much.
Thank you so much, Mr. Strenk, for this excellent and illustrative talk on grossing key concepts. I think this would be really very helpful for the new trainees and the rest who have just joined pathology or pathology assistant school, and also to our colleagues who have joined from different parts of the world. Thank you so much, Mr. Strenk. There are quite a few questions online, so let me read them for you. So the first question is, do you find the Q-tip a better applicator of ink than a brush?
I do, yes, because you can get, it's smaller for one thing, and you can get a more finer line. It's especially good for smaller margins. And sometimes I'll even use the opposite end of the Q-tip, just kind of the wooden end of the stick, and you can get a really fine line with that if you have a really small area. So yeah, I like the Q-tip much better than a brush.
Yeah, that's a very interesting point that you have mentioned about the opposite side of the Q-tip, because that is so useful sometimes. I remember my own grossing days that, you can actually apply the ink very nicely on the margin without spilling it over to the surface, right?
Right. Yeah, I use that a lot on really small skin specimens because it doesn't run over.
Right. And I think, I mean, all over the world, because we have audience from different countries. So Q-tip is, I mean, it should be very easy to procure, and we can use it and for specimen inking, especially margins. Like if it is a bigger surface, as Mr. Strenk will agree, so, you can be more generous, right? Suppose you have a lumpectomy, you have a bigger surface that you are like, inking maybe the deeper surface with the with whatever color you choose. So then maybe like
Mhm.
you can be more liberal in using the brush or the Q-tip. But yeah, on smaller margins, like, which are very close, so we can be a little bit careful. Otherwise, once the ink spills to the other surface, then it can be, very difficult when we see it under microscope, right?
Right. Yeah, definitely. And actually for, larger specimens, say mastectomy, if you need to ink a large surface, I'll use sometimes I'll use gauze for that. Kind of dip it in the ink, and then you can spread it along a larger area.
Right. Yeah, and I mean, like crossing or inking is different in different parts of the world, even if we don't realize. And I have the experience of working in at least two other countries, and I know that inking is not taken very seriously everywhere, but it is something that is so important, and it is very easy too. And one question that always comes to mind to many of our viewers and to all of us, I think, is that, like, what are the different colors that you use? I think somebody is asking that question for lumpectomies. And I mean, you can guide them, Mr. Strength, because the easy keys that we use in inking the different margins, for example, in a lumpectomy specimen, because I think that, I mean, this is one classical example of a specimen where multiple margins are there and inking
Right.
plays such an important role, and you have to use multiple colors. Can you please elaborate?
Right. For lumpectomy specimens in particular, we have a system that we use. So there's 6 margins, so we have 6 colors, and the way that we remember it is superior is blue, so superior is up, the sky is up, the sky is blue, right? Inferior is green, green is grass, so green grass, blue sky. We use black for deep or posterior because deep is often the most important margin and black is easiest to see. And then medial is red. So if you take the first 3 letters, med, red, that one's easy to remember. And you just have 2 other ones to remember. So the lateral is orange. I don't really have a clever way to remember that. And then the anterior or skin surface on a lumpectomy is yellow. So that's the system that we use. And like I was talking earlier about using a system, you want to, if you're going to ink something like this, do it that same way every time. Because if you need to go back to it and you can't remember what you did, or for some reason your gross description gets lost, you'll know that what color means what margin because you always do it that way. So I think, you don't necessarily need to use the same colors for the same margins like I do, but you should do it. You should pick a way to do it, pick a system and do it that way all the time, whether it's a mastectomy, a lumpectomy, or any other kind of specimen.
Yeah. Thank you, Mr. Strenk. I think this is something very important that Mr. Strenk has mentioned to all of us, is that whatever color code you are using, keep it consistent, so that, like, in
Yep.
that lab, at least you use the same color code for that specimen all the time. I mean, and that makes it easy for everybody. And also, like, one thing that to be kept in mind is that whatever is the color code we use, so we need to mention it in the gross description.
Yeah.
Otherwise, it's not easy for anyone to remember later which color meant what. So that we should never forget. And in that line, there is another question for you from one of our viewers, is that say, for example, we just now talked about using different colors in a lumpectomy specimen, but in the lab, suppose there is only one color available. That is a practical problem, Mr. Strank, in many countries. Suppose you have only
Yeah.
one color available, what do you do? So that's a question from one of our viewers.
Hmm. All right. That's a difficult one. But what I would say is if you've only got your one color, obviously you're going to have to ink the whole specimen that one color and section it in a way that you can show the margins individually. And then whatever tissue you have left over, you'll have to separate. And then, like, we'll often wrap things in paper towels and label them. So you can separate, say, your anterior margin. You can separate all those specimens that still or all those sections that still have that margin, label it that way: posterior margin, medial, lateral, all of those things. And then you can save them separately, wrapped in paper towel or something like that. So if you need to go back, you'll be able to differentiate the margins. And then when you put your sections in the cassettes and you do your cassette summary and your gross description, make sure you say in the cassette summary which margins are in which cassettes, because they're all going to be the same color.
Right. I think that is important, and I mean, it's a problem like we face in many laboratories, if
Yeah.
not in the developed world. But I mean, if we mention it, right? I mean, which cassette is which margin? So I think even if we use one color, so we are good, right?
Right.
So in that case, we have to be careful that we do not submit opposing margins, like, I mean, in the same cassette. So then it will be a problem, right?
Yeah, I think in that situation, you could only have one margin in each section.
Exactly.
Yeah.
Right. Right. Thank you. Thank you so much. There is another question, continuing with the color code. So that you showed in the video that you are using a spray. So what is the spray that you are using? That is one question from one of our viewers.
Oh, it's acetic acid or vinegar. Um, it's kind of the same thing. It helps the ink adhere to the tissue. That's all it is. It's nothing fancy.
So it's commercially available,
Yeah.
isn't right? And so if it is not commercially available in some parts, so is there an easy solution, like they can just use any vinegar?
I think so. Yeah. I mean, in the past we've used just straight vinegar. Just you get it from the grocery store or something. Just a big bottle of vinegar, and it works just fine.
Okay, so that basically helps in sticking the ink to the surface, isn't it, right?
Yeah. Exactly.
So regarding color, so there is one practical problem we face is, so there are some colors which are better avoided, right? I mean, if there is a specimen like lumpectomy when we have to use multiple colors, that is fine. But suppose, I mean, in some specimens, we don't need multiple colors, right? What are the good colors and what are the bad colors? Like some colors are very difficult to, interpret
Yeah.
when you look at microscope. Can you help us with some guidance?
Well, I would say the best color is most of the time, anyways, is black because it shows up the best on the slide. The exception to that is if you're working on a melanoma specimen, you don't want to use black, and so in that case, I would use blue. Blue is probably the second best color because again, shows up very well. Green as well. Uh, you run into problems with red and orange and yellow. They don't show up as well, especially red, because it can kind of blend in with the H&E stain with the eosin. And yellow and orange are sometimes microscopically anyway difficult to tell the difference between the two of them. So I would say your three best bets are black, blue, and green.
No, thank you. I think that's a very, very important hint because, we have faced this problem often. We have options of using different color and we end up using red, orange, or yellow. Then they are really not very helpful, right?
Right.
So let me ask some other question from our viewers is, mm, what kind of tissue ink, commercial name that you use? Do you have any names like, which are useful? Of course, you can have.
I mean, there's a lot of them. I think Davidson is probably the most widely used. The ones we use come from CDI, which I like better because I think they're thicker. I think they cover the tissue better, and they don't. Some of the inks kind of wear off a little bit, and I think for me, my kind of personal opinion, just an opinion, I think CDI is a good ink. But some other companies, I know Mopec just came out with inks now, and there's some other companies that have ink as well that I haven't tried. So, but they're all pretty good.
Right, right. And yeah, we have to add a disclaimer that we are not promoting any particular brand here.
Right. Of course. Yeah.
So whatever works best for you guys, you can please use in your lab, isn't it?
Yeah.
So there is one question from, again, staying with ink. Ink is a very, I think, a tricky issue for all of us. So do you use any color reference in Whipple specimen? How do you orient the, I mean, yeah, I think let us keep at that. So what color code you use for Whipple specimens?
Yeah. So for Whipple specimens, we use 5 colors. So the pancreatic neck margin is orange, the vascular groove is green, and then we call it the SMA, or the uncinate or retroperitoneal margin. It's all the same thing. That's black. And then the anterior surface, again, surface, not a margin. The anterior surface of the pancreas is blue, and the posterior surface is yellow. And then the way that we cut them, because we cut them, I think it's called the axial method. So you'll cut them superior to inferior. So it basically gives you a perpendicular margin to all of those, all the margins in the surfaces. And oftentimes the pancreatic neck margin is submitted for frozen section anyways.
Right. So, I mean, of course, we need to have a separate talk for Whipple alone. So because
Yeah.
we are talking about margins, so I think one uh, question that comes very often on Whipple specimen is unfast versus perpendicular margin. I
Mhm.
mean, you can correct me if what is your practice. So I feel that in most of the places for pancreatic neck margin, even when it is sent for frozen section, we use unfast. But for the uncinate margin or the retroperitoneal margin, we usually do a perpendicular section. So is it what you do at your practice, Mr. Strenk?
Yeah. Yes, it's exactly the same. In fact, with the uncinate margin, we'll ink that black, and then you shave off the whole margin and then cut that perpendicularly, which so you still get that whole margin, but a perpendicular section, like you said.
Right. I think you guys all understand what Mr. Strenk is talking about, perpendicular sectioning of the uncinate or the retroperitoneal margin, because that word is used differently in different parts of the world. So here we use more often uncinate margin, and it is
Mhm.
something similar when you do perpendicular margin of lumpectomies, right? So you basically slice it first and then take perpendicular sections so that we have ink on the surface, and then the other surface is towards the specimen. Is that what you mean, isn't it?
Right. Yeah. And even the two ends of the lumpectomy specimen, we would still cut those perpendicularly as well. So all of the margins in a lumpectomy specimen, the way that we do it where I work, are perpendicular sections.
Yeah, right. I mean, this is again another contentious issue and very important to remember for all of us is the perpendicular margin versus shape margin, isn't it? Right.
Right.
And as you rightly mentioned that for tubular structures, you would prefer to take, a shape margin, right? And you would take a perpendicular margin only when you see that the tumor is closer to the margin so that, you can include the tumor and the margin in the same cassette, isn't it?
Right. Yeah. I like to use perpendicular margins as much as possible because I think they show the relationship of the tumor to the margin or the tumor to other structures a lot better. I mean, shave margins have their place if the tumor is far from them and some of the tubular structures, but for the most part, I like to use perpendicular margins.
Right, right. For tubular structures, like for example, we have a lot of colectomy specimens or
Yeah.
other, esophagogastrectomies. It's for the viewers. I think because most of the time the tumor is far away. So, I mean, the standard of care also has to be a shave margin because in a tubular structure, say for example, we are looking at signet ring cell carcinoma of the stomach. Even if the tumor grossly is far away, so the signet ring cell carcinoma is notorious to diffusely spread. So if we by mistake submit a perpendicular margin, which is really not representative, and it can misguide us because at least we need to submit the shave unfast margins so that if there is any chance that, we might find some tumor cells, and without that, so I think it won't be correct. Don't you agree?
Yeah, I definitely agree. Yes.
Right, because I have seen in some places so that that for tubular structures, perpendicular margins, I don't think that we should submit perpendicular margins for tubular structures, right?
The only time I would disagree with that is if you have a urothelial cell carcinoma and you've got it's a visible tumor in the ureter that is close to the margin, then you would ink the margin and take perpendicular sections of that. That would probably be the only time I would say on a tubular structure to do a perpendicular margin if the tumor is close to that margin. But otherwise, yeah, the shave margin is the better way to go.
Right. And sometimes what happens, like if we take a shave margin, for example, a gastrectomy, so we might actually need to submit multiple cassettes, right? Because the
Right.
gastrectomy sleeve, the gastrectomy shave margin, I mean, like the margin is usually very long. So, but I think that one way maybe that we can submit couple of, sections in one cassette, but we can still get around it. Don't you agree?
Yes. Yeah, definitely.
Right. So there is one question about the 1 centimeter rule, Mr. Strenk, from one of our viewers. So so do you have any reference? Because the viewer wants to know that is there any reference that you are citing it from, so that they can mention it to their administrative people in their lab.
That's a good question. I know I don't. That's just something that I've always heard forever, and everybody kind of has that same mindset about it. The one section per centimeter. That's an interesting question. I think I'll look that up and see if I can find an actual reference for that.
So yeah, I mean, with that 1 centimeter rule, I just want to add, and Mr. Strang can comment on it, that it's also like not one size fits all. So we have to be
Right.
careful. Like for example, we have fibroid specimens which sometimes come morcellated, or we get a huge 25, 30 centimeter fibroid. So then even though we have to do 1 centimeter, one cassette per centimeter, so I don't think we will submit 30 cassettes, isn't it?
Right. Yeah. And sometimes, I mean, it's one section per centimeter, so you can sometimes do two, maybe three in a cassette, and so you'll have less cassettes that way.
Right, that can be very useful in a big fibroid. So as
Yeah.
Mr. Frank has mentioned, we can put three sections in one cassette, and still it will represent, 1 centimeter, one cassette per centimeter. But in
Yeah.
sarcomas, so we have to be like really more careful, because it can be a heterogeneous tumor where more active areas, maybe misrepresented if we do not follow the 1 centimeter rule, isn't it?
Right. Yeah. And like I said, the 1 centimeter rule, I mean, that's a minimum. And you can often go over that. And yeah, and sarcomas are a good example. We often go do more sections than the 1 centimeter or one section per centimeter.
All right. And sometimes it is, some tumors are more predictable. For example, like say we are looking at a very homogeneous tumor in the salivary gland, or
Hmm.
a benign like oncocytoma like tumor in the kidney. So maybe we can be a little bit more liberal, and be sensitive at least, that how many sections are needed. And probably the best way at that time is to talk to the attending pathologist that how many sections they would want, right? And
Right.
sometimes like a colon tumor which is big, but as we know that not in all tumors the size is important for tumor staging. For example, in a colonic tumor, it is the depth of invasion which is important, right, for
Right.
stage, for correct staging. Then even if it is a bigger tumor, so the more important it is to take sections, full thickness sections, which will include the serosa, but not the number of sections that are there, isn't it?
Yeah. Right. Exactly.
Right. What other questions? Let me see. I see. Yeah, someone has mentioned in the chat box that one can use tattoo ink, for inking specimens.
Sure. Yeah. I've
And
I've never actually done that, but I've heard of that works.
right. And Another viewer has mentioned that about a book that Lester's Manual for Surgical Pathology mentions the 1 cassette per centimeter rule. So I
Oh,
think,
okay. There you go.
and yeah, maybe for our viewers, you can suggest from some good reference textbooks for grossing at this point, Mr. Strenk.
I mean, there's really two that everybody uses, and the Lester book is one of them, and the other one is Ruban. It's the I think it's called Manual for Surgical Pathology Dissection. Those are really the two that I think, at least for pathologist assistants, those are the two that everybody uses.
Right, and I think these two books should be good for all residents and
Mm-hmm.
pathologists who are keen on doing a proper grossing with good guidelines, right?
Right.
And there is a new book which has come up from CAP. So last year, I think that book is really very good about grossing. So it touches a lot of good points. So that book is also available online about
Mm-hmm.
specific grossing.
Actually, since you mentioned CAP, it's a good idea to look at the cancer staging protocols from CAP, because it'll tell you what margins and what sections you need to have in order for proper staging, and so you can use that as a reference as well to determine what kind of sections you need to take on a case.
Right, that is something very important that you have mentioned. And for our viewers who are joining us from different parts of the world, so the CAP cancer protocol is available online for free. And that there is and I'm sure most of you know about it, that there is a cancer protocol which is separate for every cancer type. And if you access those, so basically it tells you about the synoptic reporting and the reporting guideline for each tumor. So that is a very useful guide for grossing, and especially for new residents who has just joined. So if you are grossing a specimen for the first time, so you please look at the CAP cancer protocol. So in that case, you know exactly that what are your important sections, because your attending is going to use the, that synoptic reporting that is there in the CAP protocol to sign out the cases, so that you know that what are the important sections that should be there. For example, if you're submitting lymph nodes, you know how many lymph nodes to submit and things like that,
Mm-hmm. Although I would say the number of lymph nodes to submit is all of them.
Right. And so, yeah, those cancer protocols are really, really very useful. And
Yeah.
another important thing that you have mentioned, and we need to highlight them again, is that the utility of, or the importance of gross description, that you have shown a template, right? And then
Mm-hmm.
do you want to elaborate on the use of templates? Because sometimes, we have seen that if a new resident is using templates, so that can get into sometimes trouble, right?
Yeah, templates have positives and negatives. They're good if you can quickly go through them and just fill in the details, but it's important not to use them as too much of a crutch. You have to know when to alter the template to fit the specimen that you have. And that's something that I've seen new residents kind of struggle with sometimes, is when knowing that they can change the template and knowing when to do that. So it's important to understand that a template is just, I tried to stress it a little bit during the talk, but it's just a guideline. You shouldn't completely depend on it, and it's not going to, you can never make a template that's going to include every possible combination of organs and structures that you might see in every possible location of a tumor, in distance to margins and all those things. So you have to be able to adjust your template to fit the specimen that you have, rather than trying to fit the specimen that you have into the template, if that makes sense.
Right. So another viewer has added on the chat box is that Johns Hopkins has free online grossing manual, which are pretty good. So maybe like,
Yeah,
so
there's a
yeah,
few others. I think UCLA has one. University of Chicago has one also. They're all good.
and especially for our viewers who have joined from other countries than USA, so please go over these freely available online resources, which really have good guidelines for grossing. And Yeah, it cannot be overemphasized that grossing plays such an important role in pathologic diagnosis of tumors, especially, of course.
Right.
Uh, so one thing that Mr. Strenk has just mentioned about the template of grossing, and especially for new residents, one important thing is that templates definitely are good, but this is the time that you learn to describe a specimen. So you should try to describe a specimen in your own way. So you will use the template for sure, because then you don't miss it, right? What are the important things in
Right.
that specimen, you don't miss it. But use your own wordings how to describe a specimen. So that is when, like, you will be in 1 year, so you will be very expert in good description. So if you use a template all the time from the beginning, then you will not be able to cultivate that skill of describing a specimen, which are very important, right?
Right. Yeah, exactly.
And another thing Mr. Strenk has shown, if you have mentioned, if you have noticed, is that uh, cassette designation, which is so important, right? Sometimes we forget that, but because the description of the gross specimen is the last chance to document that specimen, because after even 2-3 months, nobody will be able to look at the specimen, but that description is all that we have. And the cassette description or the designation of the cassettes are so important, as you have shown on that example. Thank you so much for that. And I
Right.
just want to add something here, like about lymph nodes designation in those cassettes. Do you want to add something about it, Mr. Strang?
As far as lymph nodes, I mean, you need to include how many lymph nodes are in each cassette and uh, whether they're intact or cut. So if you've got a lymph node that you've bisected or trisected, you need to include that, and you would say one lymph node bisected or one lymph node trisected, so that whoever's looking at those slides doesn't, they see, 2 pieces or 3 pieces, and they think, okay, that 2 lymph nodes, is that 3 lymph nodes, and so you have to include that was one. And another trick you can do, if you've got 2 lymph nodes that are relatively the same size, you want to bisect each of them, you can ink one, usually black, maybe blue, and then you bisect them both, and you can put them in the same cassette. But then you have to include that it's 2 lymph nodes bisected, one inked black or blue or whatever color you happen to use. So you can use less cassettes that way. That's a little trick you can do, but it's always important to include how many lymph nodes are in each cassette.
Oh, thank you so much, Mr. Strang. This is something so important that you have mentioned, and that the importance of mentioning in the cassette designation how many lymph nodes are there. Okay,
Yeah.
sometimes it's not possible, because then we can say possible lymph node candidates. But if
Right.
you
Yeah.
do it for all the time, then that's not correct. Like, I mean, we have seen grossing descriptions sometimes. So all the lymph node cassettes are possible lymph node candidates. That's not correct. Like as Mr. Strength has just mentioned, that the beautiful way to submit two same size lymph nodes is ink one of them, right? And if you're bisecting it, ink one of them and leave the other. Otherwise, it will be so confusing. So the attending pathologist will think that there are 4 lymph nodes if you
Right.
have not included it in your gross description. So in your description, you definitely should mention how many lymph nodes are there in that cassette. And if you don't know, like there are more small ones, so it's okay. So that is not a problem. And suppose, as Mr. Strenk has mentioned, suppose there is a big lymph node, which is bigger, but you want to submit entirely, then also you should mention it in your description that cassette A1 to 1 lymph node serially section. Otherwise, this will really give a wrong description, or wrong, like, assessment when the pathologist sees it. Because as we all know, that number of lymph nodes is so important and so vital. How many lymph nodes are positive, or if positive, that really determines patient's further treatment. So even though it is a tedious process, lymph node dissection, and more than that, designation in the cassettes about the lymph nodes is really very important, as Mr. Strength has mentioned. So thank
Right.
you for that.
Hmm.
So there is another comment from one of our viewers, is that
Okay.
there are CAP protocols and also RCPAT, Royal College of Pathology data sets for grossing. So yeah, I think this is something important, right? Like, I mean, it, Royal College of Pathologists of UK. So they have also very good grossing data sets that our viewers can use. Right. I think thanks
Yeah.
to our viewer who has given that comment. Yeah, we can choose both. I mean, it's the,
Mhm.
I mean, wherever which system is followed.
Right. And I think even in Australia, they have their own set of protocols too. I'm not sure what it's Royal College Australian pathology, maybe something it's similar. But yeah, they have got their own set as well.
Right. So I think, Mr. Strenk, we has come to the conclusion of today's talk, and it was a pleasure to have you. And you would be really glad to know that this was a very well attended lecture today, and we had close to 200 viewers who have joined from different parts of the world, and I could keep track of some country names like Sudan, Finland, Slovakia, Egypt, Bangladesh,
Wow.
Yemen, Qatar, India, Serbia, Ukraine, to name a few. So thanks to all our viewers who have joined us today. And if you like our lectures, so don't forget to subscribe to our YouTube channel, that is Patcast, and the Facebook page. You can follow our Facebook page with the same name. And we also have our website, that is pathologicast.com, where all the lectures, you can find them organized by subspecialty. And as you know, Mr. Strenk has mentioned about his own podcast. So please follow his podcast as well, and you will get to
Thank
know
you.
different pathology people, and maybe you can hear our story as well. And thanks to Mr. Strenk, so Emilio and I, so Mr. Strenk has invited both of us for a podcast, so you can know a little bit about our journey in podcast as well. And Mr. Strenk is really doing a great job on his podcast, so you can follow it as well. So our next lecture is actually coming up soon. So that would be on next week, that is August 16th. And we will be switching to a talk on obstetric pathology. And our speaker will be Professor Theonia Boyd, who will be joining us from Texas Children's Hospital. And the topic is meconium and nucleated red cells, markers of intrauterine stress. So again, that's on August 16th at 12 p.m. Eastern Time. Hope to see you all then. And thank you again, Mr. Strenk, for today's excellent talk. Thanks so
Thank
much.
you. This is fun. I'm glad to be back.
Thank you.